So welcome to this session. My name's Ian Green. I'm the Customer Relations Lead for Europe and the Clinical Engagement Manager for SNOMED International. So this presentation has two elements. So the first one is a bit about the understanding of the structure of SNOMED CT. And then my colleague will follow on looking at how we can leverage some of that structure to get benefit from SNOMED. So without further ado, first of all, the purpose of SNOMED. So the reason we have SNOMED is to represent clinical information. It's recorded by healthcare professionals, it's used at the point of care, and it provides a level of detail required in clinical practice. It's used to both retrieve and analyze health information, and that's based on the meaning of the data, and it uses various levels of abstraction. It's for use by all healthcare professionals and also patients, researchers, organizations, public health, and a lot of other use cases. It's really there to ensure that we can share and integrate data across systems. So the biggest use case really is around interoperability. So a bit about the structure of SNOMED itself. SNOMED really has three very separate ideas, if you like. The first one is around concepts. So everything in SNOMED is represented by a unique code. And that code represents a concept or clinical idea, and it has a unique identifier attached to it. So here you have an identifier, they're all numeric, and they're locked. So the concept has a unique identifier, it doesn't change. And that's important because it enables meaning-based queries. Alongside that are descriptions. So the first concepts are really machine readable, where the descriptions are human readable terms, which are then linked to the concepts. So the example here, you have a concept, which is myocardial infarction. In brackets, you have a semantic tag, so it tells you it's a type of disorder. But myocardial infarction can also be known by a number of different synonyms. So myocardial infarction, obviously, but also cardiac infarction, heart attack, myocardial infarct, and even the acronym MI, so MI for myocardial infarction. But within SNOMED, as well as the concept and descriptions, we also provide relationships, which provide the association between concepts within SNOMED. So myocardial infarction itself has a number of attributes and values associated with that, which tell you things about myocardial infarction. So myocardial infarction is a type of myocardial disease. And also myocardial infarction has a finding site of myocardium structure. And within SNOMED, I've put this diagram, which I'll cover in a couple of slides, but within myocardial infarction tells you that it has a number of parent concepts that it's linked to. So myocardial infarction is a type of necrosis of an anatomical site. It's a myocardial necrosis, it's myocardial disease, and also IHD, so ischemic heart disease, as well as the associated morphology being an infarct, and then the finding sites being myocardium structure. Underpinning all of that, so the attributes and the relationships are governed by the SNOMED CT concept model. And these are rules for how we define concepts within SNOMED, and they provide both the domain, the range, and also the cardinality of constraints, so how many times you can use that constraint. We provide those in a machine-readable format, so the machine-readable concept model really provides a computable, processable representation of the concept model itself, and it's distributed with SNOMED as part of the international release. So here we have an example where you have a domain, so you have a clinical finding, you have attributes, and you have a range. The example here, so clinical finding of fracture of bone, will have a finding site of bone structure. So within SNOMED, all of that then forms together to form a very large polyhierarchy. But the polyhierarchy itself is governed by the ISA relationships. So everything within SNOMED and the way it appears within the hierarchy is governed by an ISA relationship. So the example here on the right, so every occurrence of A, every instance of A is also an instance of B. And equally, some of these below, so the 3 below A, would also be instances of A. And that governs the hierarchy and assists with really using that hierarchy then for analysis, for data analysis. And really, a lot of that is then governed by description logic, which then enables inferences. So the example here, you have a fracture of bone, which has a finding site of femur structure. The fracture of bone, because it's an ISA relationship, is a type of fracture of lower limb, which is a type of fracture of bone, which is a disease. And also fracture of femur then, by definition, must be a type of disease. But equally on the attributes and the value side here, so femur structure itself, which is a value for fracture of femur, is also a type of bone structure of lower limb, which itself is the attribute value for fracture of lower limb. And bone structure then is also the attribute value for fracture of bone. So the logical progression is not just on the ISA relationships, but also governs the values themselves that are used then to define those concepts. One of the things that we like to really get people to use is the international browser, or a SNOMED browser. So the example I've got here is our own browser from SNOMED International, and the URL is down the bottom here, so browser.ihcsto.tools.org. The browser itself enables you to go into SNOMED and see SNOMED, see the hierarchies, to search for concepts within SNOMED, and really to get an understanding of the structure of SNOMED and really find things which are usable to you as clinicians. When you go into the browser itself, you'll see the landing page, which is what you see in front of you here, has a number of different tabs. So the examples I'm going to use, we're going to use the international edition, but equally internationally, we also provide a Spanish edition, which is a little historic about the reason why we do that. But equally, each of our member countries then can provide their own local extension. So here we have the Argentina extension, the Australian, Belgium, and so on. You also have the ability to search across all editions. So down here, you can search all editions, which will actually search across all of these. The local extensions will also, in a number of cases, include the translations of descriptions. So for example, the Belgium edition here will also include Dutch translations as well as French translations, and the descriptions there are available in Dutch and French. Not completely, so some of this is work in progress with a number of editions, but the translations are included. If you then select the international edition, the first page you'll come to really is what you're looking at on the screen here. And the easiest way to understand it really is to think of the screen in two halves. So the left-hand side here, I've highlighted here the taxonomy. So this is the taxonomy of SNOMED itself. And the little arrows you see here, where there's an arrow, if you click on them, it'll expand out to the hierarchies. And you can keep doing that until you hit a straight line next to it, which means there are no further concepts below that. Then on the right-hand side, you have details. So the summary here, you automatically go to the summary page, which gives you parents, it gives you the children, and then the blue box in the middle then gives you the detail. So at the moment, this one is pointing to the top level concept here. And then there are a number of other tabs. So details, diagram, expressions, reference set, members, history, references. I'm not going to go through all of these. But within that then, so that's the taxonomy view, but then the one which is most usable in some ways is the one next to it, the search tab. So the search tab enables you to select a term within the search box. As it says here, you need at least 3 characters. What it then does is pull everything back from SNOMED with those characters. So obviously the more characters you put in, the more accurate the search. So here I've put diabetes in. You'll see that there are 782 matches within SNOMED. And then there are some details then on the right-hand side here, which tell you a bit more about the selection you have here. So for example, out of that 782, you'll find 609 are linked to disorders, but also then 46 of them are linked to procedures, and so on. On the summary page, as I said before, the top level here gives you the parents. So I've selected diabetes mellitus, which has a parent of disorder of endocrine system and disorder of glucose metabolism. It then gives you the surname, so diabetes mellitus has a surname of diabetes mellitus, not surprisingly, but then also has a surname of DM, which is also an acronym for diabetes mellitus. It also then gives you details here. So diabetes mellitus also has a finding site of structure of the endocrine system. And then below, it tells you about the children, so the subtypes of diabetes mellitus. And diabetes mellitus itself has the 15 here are the immediate subtypes. So if you notice, as I said previously, where there are arrowheads here, these will expand out into hierarchies within their own right. Where you have a straight line here means there is nothing below it. So diabetes mellitus due to pancreatic injury is a leaf node, what we refer to as a leaf node. So there's nothing below it. There's no hierarchy below it. The other thing to note here is you'll note right in the top right here, you have 2 boxes for stated and inferred. We usually use the inferred view. So the inferred view is the view that you get when you take the SNOMED release and put it through a classifier, and that's the view which builds up all the hierarchies. The stated view is the view that you get with the attributes that we allocate as part of the authoring process. It doesn't add any additional linkages within SNOMED, which you get with the inferred view. So the inferred view is the one that you would use in practice, if you like, in systems. And then finally, I've put this one up really to give you or to point you at the tab which says diagram. So SNOMED itself has something called the diagramming standards. So these really tell you how to view a SNOMED concept in diagrammatic form, which is sometimes easier to understand. So here you have diabetes mellitus. It tells you that it has an ISA of 2 types here. The blue and the lilac, or the purple here, the purple means that it's primitive, so there are no defining attributes of disorder of endocrine system. The blue, so disorder of glucose metabolism, there is. It's what we refer to as fully defined. So it has some attributes associated with it. Those attributes are enough to differentiate it from any other concept within SNOMED. And as you go down here, you'll see there's a yellow one here, which is the attribute itself. So the attribute is finding site. And then the same again, you'll have a value of structure of endocrine system. And the blue, so exactly the same structure of endocrine system, is a fully defined concept within SNOMED, which is why that appears as blue. And if you wish to, there's a tab up here where you can download the diagram. So you can download this and then use it as I am within presentations or for other reasons. And I'm going to stop there and then hand over to my colleague. So I'm going to stop sharing. Okay, so we've now moved from the presentation into a live demonstration. So I'm going to take you into the SNOMED CT International Browser.
Ian, while you're here, and I've just joined Ian. My name's Charles Gutteridge. Do you want to just point at the machine readable concept browser indicator on this screen?
Yes, I will do. I was just going to explain. So when you first log on to the browser, you'll have this box in the middle, which is really just the licensing agreement saying that you won't use and abuse the data in SNOMED. So if you click on accept, and then the view that we had before appears here. As I mentioned, we have all the local extensions, we have the international editions. We also, though, have the MRCM, so the Machine Readable Concept Model Browser. So if you click into the browser here, let me just get rid of, whoops, let me just get, ooh, won't go, oh, okay. So once you go into the browser, the Machine Readable Concept Browser, what you'll end up with then are all the different domains. So if you click on, say, clinical findings, then clinical findings tell you that if you're looking at findings, any findings within SNOMED, the attributes that are available to you to describe that concept are listed down here. So everything from associated morphology right down to has interpretation, occurrence, and severity. And then equally with these, so if I click on associated morphology, then on the right-hand side here, you'll get the attribute ranges. It'll give you the rules which underpin this, and they're expressed in using the SNOMED expression constraint language. There is a rule strength. So this tells you whether something is either mandatory within the concept model or whether it's there as a qualifier value, so it can be used or doesn't have to be used. And it also gives you then the results matching it. So these are basically the values for the attribute. So you'll see here there are within SNOMED there are over 5,000 values used with associated morphology. But the machine readable concept model is a good way of gaining an understanding of the way SNOMED itself is structured.
And I think it's one of the great ways as you're developing your skills in SNOMED CT to really explore the potential for analytics and the kind of cohorts of patients or patient data that you might be interested in. And by extending the expression constraint sentence in the attribute rule, you can really begin to drill down into much more refined and defined associations of data and begin to see how you might use this for analytical purposes. So great demo, Ian. Shall we move on to the rest of the browser?
Yes. So let me just oops.
One of the things you'll see is that the definition of the values by the expression constraint in this will also be discoverable in the browser.
So if I go back to the main page, the one thing I would point out, which sometimes people are interested in, there is also a tab for release stats, which will actually tell you for every release that we publish, the amount of concepts, the amount of descriptions, relationships, which is sometimes interesting, but also obviously changes over time as SNOMED itself either has new content added or indeed has content which is withdrawn from current usage. The one thing I didn't mention, which is important, particularly with the analytics, which Charles is talking about, is that everything within SNOMED CT from its first release is included within the current SNOMED release. So within the release, things are either marked as current or they're marked as inactive. Inactive just means that if you're Charles, if you're other clinicians that are running a current system, you don't have those appear in your pick list. So you can't choose to use them as a current reference. But it's incredibly important when it comes to analytics to use the data, that concepts that are no longer available, but were very common, not even that long ago. So 3 or 4 years ago, things which were common, which are no longer in current usage. So having the historical data within that is incredibly important when it comes to analytics. I've obviously described some of this in my slides earlier. The one thing I would add to, so just walking, if you like, some of these tabs on the right-hand side here. In terms of the tab for details, really just gives you a summary of the concept that you're looking at. So at the moment, this is clinical finding. It gives you the SNOMED ID. It tells you that it's a primitive concept. It then tells you a number of things about it. So it tells you here the F is for fully specified name. So the fully specified name, you can always spot them if you like, because there's always a bracketed element, which is the semantic tag. So this tells you that it fits in the findings hierarchy, is a type of clinical finding. It has a synonym of clinical finding. And here, the reason it appears twice, in the international release, we publish it in US English. And then I won't make a reference to correct English, but in UK English. And you'll see here that in both cases, they are the same. With a number of other concepts, you'll find they are different. So if you search for things like hemorrhage, hemorrhage has a different spelling depending on whether you're looking in US or UK English. And then it tells you it has an attribute, which is the is a relationship I was referring to earlier. So clinical findings itself is one of the top level domains. So its parent concept is just SNOMED CT concept. The diagram we touched on before. Obviously, this one is very simple because there's no modeling against it. But then if you go onto the expression tab, so this really is when you're starting to move and look towards using data for clinical analytics purposes. So really this gives you details of SNOMED expression. Clinical finding maybe is not the ideal example. So if I search for hemorrhage, okay, let's do this the easy way. Oh, here we go. So if I search for something like clinical hemorrhage here, when you search in expressions, obviously gives you quite a long and detailed view of what this is. The expression gives you all the details of the modeling, so not just the fact this is hemorrhage of kidney, but also that it's a type of disease. It also gives you the role group, which is one of the ways that we use to model concepts within SNOMED. And it will link together associated morphology, which is hemorrhage. It will also give you finding site of kidney structure. And then these expressions then can be used when you start to run expressions against large data sets and restart to really interrogate some of that data. I'm not going to explain that here, but just to mention that we've recently moved away from our older way of defining SNOMED to now move towards axioms. Axioms simply refers to the way that we group these together and the way that SNOMED itself is structured when it comes to using attributes and values. And I'd encourage, if you're interested in axioms, there are a number of articles that we've, or conference pages, web pages that we've used, which give you further details. Those are available if you go on to the SNOMED International Conference site and simply search for axioms.
And I think it's, Ian, here it's worth saying that obviously if you were doing analytics, one of the richnesses of this is that if you wanted to query your database for any finding site where the finding site is kidney structure, then modeling everything in SNOMED CT allows you to do that and to find every case rather than doing string searches on a database or producing a registry of conditions. This way you can get to the identification of things of interest, but using the inference structure of SNOMED CT.
Indeed. Thank you, Charles. So just moving on to the one next to it is something called reference sets. So this just tells you that hemorrhage of kidney appears, which reference set it appears in. So here it appears in the ICD-10 map that we published as part of the international release. It also appears in the CTV3 simple map. So if you know the history of SNOMED CT itself, it came from a combination of SNOMED RT, or SNOMED reference terminology in the US, and CTV3, or clinical terms version 3, which are part of the read codes in the UK. And it was an amalgamation of the two. So this just tells you that it appears in the map going back to clinical terms version 3. The only other thing I'd mention here, which is actually quite useful, is the references here. It tells you where that concept is used to define other concepts. So the value really has been used here in hematoma of kidney, and also within the neonatal hemorrhage of kidney. So it tells you really not just when you look at the details of the concept itself and how it's defined, also using the references, it will tell you how that concept is then used to define other concepts. Sometimes this list is very short, as in this example here. Sometimes you'll find it's very long. So if you look at things like fracture of femur, you'll find it appears in multiple concepts throughout SNOMED. So in the interest of time, I'm going to stop there. Charles, do you want to add anything to what I've said?
All I would say is that for beginners, I really would encourage you to explore and experiment with the browser. You can't harm it, you can't take things away, you can't break it, but you can have a very useful time, and you can start to create the kind of data sets that you'll be interested in for your clinical practice.
So thank you, and we'll move on.
Good morning. My name's Charles Gutteridge. I work in London at Barts Health NHS Trust, as well as for SNOMED CT. And I'm going to try and show you some examples of how we use our system of electronic health records and data analytics powered by SNOMED CT. Where I want to start, though, is to talk a little bit about history taking. That's obviously the core of making a diagnosis, is actually consulting with a patient, listening to their story, listening to the things they tell you about themselves, and finding a way of noting that. In the past, we all wrote it down. We wrote it down in the languages that we use, and that data was extremely useful if you had the patient in front of you and you had an electronic health record next to you, and you could look at what other people wrote about the patient and made your own interpretations, checking with the patient. And as medicine has expanded, as knowledge has expanded, I think now we would also take histories about genetic determinants of health. We'd certainly want to take a history around the social determinants of health, but these days maybe we would also ask about climate change and environmental change and so on. And if you note all of that down in free text, essentially it's lost to you except at the point of care in a record. So it's absolutely crucial that we structure the data in ways that are computable and accessible at any time, at any point, and also potentially that we can hand to the patient in an electronic form that they can use when they travel or when they're at home and trying to maintain their own health. So structuring the data is, I think, one of the things that we have to find better ways of doing than we have historically. And the systems that we need to use to make that happen must be fast and easy to use. And very crucially, they must be easier than entering free text. My experience of encouraging doctors and nurses and other healthcare professionals in London to use electronic health records and use the structured data is that at any opportunity, they will use free text rather than structure if it's faster to do. And that's really not a surprise. One of the ways to make it faster is to ensure that as you develop your electronic health record, that you work through the workflow for each item of care, and that the creation of data in that workflow is just part of what people do as part of the work of looking after a patient. I think it inspires most people if the data can be reusable in that record. In other words, that you can take a piece of data you entered in 3 months ago and add it to the current view that you have, or illustrate documents and letters to other people and so on, or as a part of the system. And I've, over the years, have developed a very strong view that teaching people about terminologies, ontologies, how computer processing actually works must be taught very early to healthcare practitioners if you're to make the move from using free text to using structure. So what am I talking about? Here is an example of one electronic health record that we use in East London, and which on the left-hand side has a tab with diagnoses and problems illustrated by the red arrow. And you can see that somebody has already entered in a chronic list a problem, which is fracture of dental root and pain in the tooth. There are no historical factors here, and at the moment there are no problems for this current encounter. Although this looks readable to you and me as ordinary English, it's actually encoded and is a SNOMED concept. And that's obviously very crucial. So how did I get those concepts into the record? Well, pressing the tab opens a control window listed problems, and I've highlighted here the add. So obviously I press add, and that opens another window where I can search in the way that Ian illustrated using the SNOMED browser, but this is obviously a browser within the health record. I think that most modern systems would use a terminology server directly connected to a SNOMED repository, but in many of the older systems, SNOMED CT is actually built into the system, and the browser works as defined by the company who wrote the software. I think it's a real advantage in modern systems to have access to a terminology server, so that the editions of SNOMED, as they're renewed every 6 months and so on, that process from a computing point of view is much simpler and easier to maintain. I've searched here on MyoInf, as you can see, and what that returns when I search by pressing on the binoculars in this particular solution is an alphabetical list of what you can see as SNOMED CT terms. This gives me a code, and this is an interesting part of this, that these are not concept IDs, they're actually the description IDs. So it's already drilling down into SNOMED for you. And it also tells you which of the hierarchies or terminology axes, as it's called in this, for the term that I'm interested in. So I'm going to choose myocardial infarct or myocardial infarction because that's what we were interested in. But you can see that when I use the contains view, it'll find all terms with myocardial infarction somewhere in the concept. So I got literally hundreds of possible offerings here, and I can constrain that by limiting the search to exact match or starts with. And if I do that, I get a much smaller demand. So learning how to use this system is pretty crucial, as it is learning how to use the SNOMED CT International Browser or your local language browser and country browser. And then you saw at the top that I could also, as Ian showed you in the international browser, begin to explore SNOMED a little bit within my electronic health record. So I could look and see the ISA relationships by pressing on concept family, and you can see that myocardial infarction is a myocardial disease, is an ischemic heart disease, is myocardial necrosis, and has necrosis of an anatomical site. So that tells me quite a lot if I'm beginning to get interested in how I might use the structure of SNOMED for analytical purposes. I can also look at those attribute values by searching on the multi-axial components. And if I'm interested in ICD-10 or indeed mapping to other systems, in this particular solution, I can see the cross maps. And in our case, in the UK, we mostly map to ICD-10 or to a procedure terminology called OPCS 4.9. I'm sure it's the same in Portugal, that procedures really drive most of the billing in hospital systems. And so the procedure coding is usually extremely old and well embedded and reaching the end of its life. And I would encourage you to think about using SNOMED CT procedure codes, which are extremely granular and very extensive. What are the data entry options that face a clinician and face system developers? Well, I've already talked about free text. And as I say, most humans prefer to use free text if they're given the option, but it is not computable or only computable with natural language processing. And that's a real challenge to do in real time at the point of care, at least in current systems. One might choose to use a higher level classification. So to use a parent term if you were using SNOMED CT, or to use an ICD-10 code if one was using ICD-10 in a system. The problem with that is usually dissatisfying for a clinician who wants to be very specific about the terms that they use to describe a patient. And most clinicians won't use a higher level classification at the point of care, and I wouldn't encourage you to do that either. You might design a system that restricted the number of choices presented. So I showed you a page where literally hundreds of possible terms for myocardial infarction were presented, and you might find a way of resolving the choice by more exotic tools than just the exact match contains and starts with type of constraints. But that, again, might frustrate the clinician who wants the whole of the dictionary. And so I would encourage you to look at systems which provide the most specific concept at the point of care. And certainly if you want deep analytics and want to be able to use your data for research purposes, then choosing the specific concept that relates precisely to that patient situation at the time is the right thing to do. So let me show you some examples of how you can use SNOMED CT for benefit. Here's a page in an electronic health record where somewhere else in the system, the patient has been measured in height and has had their weight measured. And that automatically powers a little algorithm that calculates the body mass index. And then that BMI value is using a simple logical rule in the electronic health record listed as a SNOMED term in the problem list, so that you can see BMI more than 30, obesity appears in the list with no further work required by the clinician. So that's a really simple thing to do, but it auto-populates the record for the doctor or nurse caring for that patient and immediately illustrates, one, the value at the point of care that you're dealing with an obese patient and all the consequences that that may produce, but also allows you to run a query on your database, essentially asking or replying to the question, how many patients do I have in my practice who have a BMI of greater than 30? Here's another illustration of a use of SNOMED, which I think is particularly useful. Smoking, as you know, is probably the greatest cause of harm to the human race, and recording smoking, encouraging patients to stop smoking and to control their nicotine addiction and so on, is one of the challenges for all healthcare systems. So here is a form with some questions asking the clinician to record smoking status and also a discussion about whether that patient is prepared to try stopping. And in our system, if the patient agrees to stop smoking, that auto generates a referral to a smoking cessation clinic close to that patient's home. So in a tertiary referral center like mine, the patient may come from many miles away and they don't want to come to a smoking cessation clinic close to the hospital or indeed the smoking cessation clinic within the hospital. They want to visit a smoking cessation close to their home. And that, with no further work from the clinician, is done by generating a letter from this form. And in addition, adding the smoking status to the patient adds a problem list, adds a SNOMED term to the problem list. Now, you might say, well, why not just add smoking? Why have these different types of smoke and use of tobacco? And in my part of London, many of the South Asian patients, including women, chew tobacco in the form of pan. Pan has a profound effect on pregnancy and pregnancy outcomes. And we think it's really important that we track and encourage women who chew pan to try and stop their habit to improve their pregnancy outcomes and improve their obstetric health. And so being able to record very granular data about tobacco use is absolutely crucial in that situation. And SNOMED CT has many different concepts for tobacco types, substances and so on. And that's very highly valuable. ICD-10 does not have those concepts at all. I've talked a little bit about reusing data for benefit, and I'm just going to very briefly illustrate some of the things we've got in London to do that. But in essence, SNOMED CT can be the data that drives a health information exchange. For a health information exchange to work rapidly and well, it's much easier if the data is structured and presented to the user clinician in any environment using SNOMED CT. There is, I think, a big movement now slowly emerging in Europe, particularly for cross-border health, where a health information exchange might be of extraordinary value across different health systems, and turning an English term in SNOMED into, say, the Spanish term using the concept IDs is something that is easy to do and would provide an immediate translation of terms accessible at the point of care, but also the potential for turning those concepts into dialects and maybe symbols for people who can't read language and so on, and have a set of terms which are patient-friendly and easy for consumption. So in London, we now use our electronic healthcare record systems embedded with SNOMED CT as the terminology to provide a health information exchange system that covers about 6 million people. And so in my practice in haematology in East London, I can view the record of about 6 million people. I obviously don't, but I could do should I need to. And all of that data is encoded in SNOMED CT, and I can see it in the hospital environment, in the mental health organizations that we help provide, in the hospices for terminal care, in all the general practice premises across London. And our system is used about 750,000 times a month to see data about a patient who is moving across the geography of health. And here's some examples of what that looks like. So here's another view of the hospital record. You can see that the patient has been a liver transplant recipient, has some concepts that others have added to the hospital record. In the electronic health information exchange, those same terms are available as a list in SNOMED CT. Here, they're presented by date term, and you can see that liver transplant is then viewable by the general practitioner or any practitioner who has access to the health information exchange. What I think is also quite interesting is that a different problem list is also viewable, coded in SNOMED CT, but produced by primary care and the general practitioners. And a very different category of SNOMED CT terms appear much more frequently than the hospital problem list, and with a completely different flavor to them. Very valuable to the secondary care physician who wants to understand what kind of problems the patient is experiencing in their home in primary care. So a very quick look through this gives us a summary of what's happened in the last year or two for this patient. And obviously interesting if you're a liver transplant patient that you've appeared to your primary care doctor with a suspected bout of COVID-19. You might say, well, where's the liver transplant in this list? And because it's listed by date and the patient had their liver transplant about 20 years previously, that appears far down the list, but does appear. So I'm going to talk a little bit more about using SNOMED CT for examining population health. And one of the challenges, I think, for all modern healthcare systems is to examine that intersection of the individual patient with their problems with the whole population with a specific problem, helping us to find cohorts so that we can understand how people present, how they use systems, how we should manage that system most efficiently and most effectively, so how we bill for it and how we can drive better use of the system, but obviously also for the benefit of the individual so that systems and services work well for them, and also that we can use the data for research purposes and for getting better healthcare overall in the end. And I want to just take an example of one system that we've built in East London that we call the Barts Pancreas Tissue Bank. This is a biobank. It holds all specimens of that patients have volunteered to provide when having a biopsy or procedure on a pancreas. The tissue is kept in a bank. It's encoded with and annotated with data in SNOMED CT. We also add to it primary care data, which in the UK is also encoded in SNOMED CT. And we have an incredibly comprehensive annotation of the pancreatic tissue bank, the tissue itself, genomic analysis of the tissue, and we're able to piece those pieces of information together for our research program for improving care for patients with pancreatic cancer, which remains one of the scourges of humankind, with outcomes that of only a year or two from diagnosis for most patients. And we think we're on a journey of discovery using the data that is generated by the analysis of tissue and annotation of the patient's life. And these are the kind of questions that patients ask themselves and ask us when we ask them for tissue, and when they're thinking about their condition. Obviously, in something like pancreatic cancer, one of the most common questions is, could the diagnosis have been made any earlier? Could my life have been saved if I'd presented earlier in the course of disease? How might have I known that the small symptoms I had were related to my pancreas? If treatment has been undertaken and partially successful, a very common question is there blood to test the track of the progress of my cancer? For cancers with a genetic element, which occurs in pancreatic cancer like all other cancers, that question about, can you predict if my children are likely to develop the same cancer, is a pretty crucial question to answer. And most people wish to help themselves and help others, and ask the question, how can I help research at your hospital? So you'll be familiar with those questions. And I'm a strong believer that annotating a record with real world data is a way to help resolve that. And here's an example that I'll give you very briefly of a study that we completed about 2 months ago, and which essentially was driven using the data built into our tissue bank. And inevitably, we were interested in saying, in that cohort of patients with hepatobiliary and pancreatic disease, where we have now a very comprehensive data set, can we understand what happens to patients who, with the underlying liver or pancreatic disease who also develop COVID-19, and can we understand the risks for them and their outcomes? So this was published in BMJ Open about 2 months ago, and is a study of the 15,000 patients in our record. I think rather importantly for European countries, 50% of the patients in our database in London come from non-white backgrounds. So we're able to examine risk for Black patients, for patients from South Asia and other parts of the world. And I think one of the things that really shows that if you have highly valuable data sets, then clinicians will complete the data fields. So data completeness in this record is 98% for all of the fields other than for substance misuse. We find that data completion against substance misuse is not always accurate or not always completed, but in everything else, we have very high levels of data completion. Overall, in that patient group, only 1.5% had COVID-19, but we noticed that there was a significant, something like 3 times increased risk of infection for men and for people of Black ethnic origin. The risk was significantly increased for patients with moderate to severe liver disease, and the odds of dying, again, about 2 to 3 times for women. The odds of dying were greatest in men, and particularly men of Black origin. So we think we understand quite a lot more about risk and how to manage services and what to do for our population. And that's done from a database where no additional information was added to the database other than a search for COVID-19 diagnosis in that group of 15,000 patients. So these are powerful engines where a study's been completed in about a 1-year period, which I think it's fair to say would have taken years to complete or never be completed at all in previous time, and where we could do this fast because almost all of the data that we have is structured, and it actually is in SNOMED CT in this particular example. So I'm going to end on this final slide and say to those of you in the audience who consider yourselves on the journey of becoming clinical informatics professionals, or already are clinical informatics professionals, to take the next steps. Today, Ian has focused on use of the SNOMED International Browser. I've provided you with some examples of how we use SNOMED CT in East London and how that might be replicated in any electronic healthcare record system in a whole range of ways. I've given you, 3 or 4 simple examples, one big study, but there are many ways that you could exploit the richness of SNOMED CT, and particularly using the descriptive logic that both of us have pointed at to find new data. And my challenge to you is to find ways of using the machine readable concept model that's easily accessible through the international browser, and then using ways of constraining SNOMED CT for analytical purposes, learn to use expression constraint language queries. And there are tools on the web for those with informatics interests. Those tools are easily accessible and can show you very interesting and exciting ways of analyzing data. So I'm going to end there and leave you, and thank you very much for inviting me to this session. And I hope we meet again either in real time or electronically sometime in the future. Thank you very much. Goodbye.